Hello, my name is Patrick Long, and I'm founder of Hero Health Plans. And today we're going to do a quick interview with one of our partners and friends, Dr. Ben Aiken. Thanks for joining us, Ben.
Good to be here.
Ben, I'm going to start off by, trying to get you to share with your audience your why. Why did you start Lantern Health, and tell us a little bit about the difference between what you're doing at Lantern Health with its direct primary care versus what a lot of people are used to, which is more like PCP or this traditional primary care. You could tell us a little bit about that.
Indeed. Sure. Yeah. So I think I came through both medical school and public health school, and in trying to determine what I wanted to be when I grow up. I fell in love with family medicine mainly because there is a ton of variety and it is relationship based. You get to know people over a long period of time, and you have to be nimble enough to really navigate anything that comes in the door. And so I was really attracted to that. What I started to see when I got into my clinical years was just dysfunction. And it became quite clear why, we have trouble recruiting people into primary care. My impression at that point was that the physicians were working harder than any that I was with in terms of trying to see 20, 30 plus patients in a day. And compared to all of the other specialties, were generally paid at the lower end of the totem pole, if not the least. And so it became pretty quickly obvious why folks tend to not go into primary care in terms of those incentives. And I really wanted, that to change because ultimately every high functioning healthcare system in the world is built on a strong foundation of primary care, and was really wanted to be a part of re-emphasizing and kind of allowing primary care to reemerge as the really foundational element of our health system in this country. So that's really what drove me.
You left the traditional system, right? And tell us a little bit about that, because that's a big fork in the road. You're employed by a major health system, and you see the dysfunction. We hear about burnout and certainly post-COVID, but you started this far before COVID, long before COVID. Tell us a little bit about that decision, and what's the big delta between a traditional health system, PCP, and what you established at Lantern. That's
absolutely. Yeah, so I think, I spent my training years really looking for anybody that would have me that was trying to do something different and study different models. Ultimately, as many physicians have to navigate, had some debt to deal with and other things. So my initial move after residency was to be in a more traditional model. Traditional primary care is what's called fee-for-service primary care. So it is a volume-driven model. Every time you deliver a service, there is a fee that you charge and route through an insurance company in order to get paid. In essence, though, there is some change in how those payments are structured with our transition to what's called value-based care. It still almost incentivizes people to be sicker, right? So the sicker you are, the more you go to the doctor, the more the doctor generates from a revenue perspective. And it's a volume game. So some will describe it as kind of like being on a hamster wheel, where you get on the wheel every morning and you just got to go, 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 go. See as many patients as you can, spend on average 8 to 12 minutes per patient in order to see the volume. And it's really hard to, it's hard to sustain that for long periods of time. Physicians are burned out and displeased, and patient satisfaction in primary care is dismal. As I studied different opportunities, direct primary care emerged as a really viable solution in which you really shift all of the incentives away from volume to being more relationship and experience driven. And then really just kind of looked for the right opportunity to kind of go out on my own and give it a shot and take that risk. And that happened in and around 2018 when I decided to do that.
And so the main difference, because I'm with a PCP provider, and because DPCs are not everywhere, and certainly DPCs of your quality are fewer and further between, although it is growing. My PCP doctor is a perfect example of what you just articulated so well. I've seen him for 5 or 6 years now, and my full name is John Patrick Long, and he calls me John. No matter how many times I've put parentheses around Patrick, I've underlined it, I've done an asterisk, I've said, he sees me for the 8 minutes. I'm sure he's a high volume guy, he's very good, but he's very efficient, but he's on the hamster wheel, which is a good analogy. And he's just cranking through the patients to get the revenue up so that he pleases his superiors in the system. And not that there's anything wrong with it, it's just a different system that he participates in. And I'm complicit because I'm going to him because I haven't found a lantern here in central North Carolina yet. But I'm also fascinated by the delta between fee for service and what you're doing. So could you tell us a little bit more about how Lantern is compensated? How do you engage with patients, and what do they pay, and what do they get for your services?
Yeah, certainly, Patrick. I think that one thing I hesitate to do is I generally don't throw physicians that are in the existing system under the bus. Yeah. Really, it's the system forces around them, and they are functioning as best they can in that system. But fortunately, there's a different path, direct primary care being my favorite of the different paths. So at its core, it's a different financial model. So in place of a fee-for-service structure, it is a membership or retainer-based structure where basically on a monthly basis, there is a fee that is paid by a patient or by someone on behalf of that patient to the practice. And for that monthly fee, you get unlimited access to primary care. So if you look across the nation in terms of different direct primary care models, that really is kind of the foundational financial approach. So it functions more like a gym membership. Yeah. And the overwhelming majority basically charge nothing from a copay perspective. So you get unlimited access. When you're not, the kind of the direct indirect primary care really comes from extracting insurance from primary care and having a direct payment between the patient or the employer and the provider. So insurance is not involved in the model. And that really decreases the overhead such that you can carry a smaller panel of patients. You can have more time with patients, longer appointment slots. Our appointments range from 30 to 90 minutes. They are not rushed. Those appointments can be in person, they can be virtual, they can be by phone. We have text exchanges regularly with our patients. We really function in the 21st century from a technology perspective, which a lot of healthcare does not.
I see a fax machine at my PCP office. So just to frame things up for you.
Fax machines only exist in healthcare still. So that's the, in essence, we are incentivized to keep people healthy. So if a patient of mine is really, really sick and comes every week, that decreases my ability to see other patients. And so I'm incentivized to keep them as healthy as possible so that they don't come and see me every week. At the same time, I'm also incentivized to make sure that they're having a really good experience, because if they're not, if I never see them, then they can just fire me. It's quite, that relationship is direct, and that's quite nice. So it's a really nice counterbalance where we're focused on delivering a meaningful value add experience for our patients, which we call our members. Yet at the same time, trying to do our best to keep them healthy in that relationship-based way.
That's great. And I know it's over the last 7 years, it's proven out through prior to the pandemic, or I guess we're emerging from pandemic, and your model has worked across in-person, online, like you said, phone, text, email. They have somebody to call a telehealth or come down and see in person. That's a special relationship. The other part of the special relationship I'd like to get your opinion on is the fact that in the traditional PCP model, there's compensation or requirements or some sort of quotas on how much business they generate for other parts of the health system. And that varies by health system. But, I know my PCP would only recommend, my doctor would only send me to get an MRI at that same hospital or see two specialists if I have allergies. But the DPC model is based on less of that kind of poke and pry and then refer, and more on, so what I've seen is there's a lot less unnecessary procedures and claims when you go to DPC. Do you find that is that a realistic assumption there that's the way it's gone for your patients?
It is. Yeah. So I think we've been fortunate. We have grown. We grew through the pandemic. That was very much not the case for a lot of primary care practices. We are prepping to open an additional location. We serve over 50 businesses in our community, as well as individuals and families in the community, and really are excited to see growth, for our own business, but also replications of this and other people starting similar things throughout the state and throughout the region. As it relates to the kind of the value proposition, the initial hook really is our patient satisfaction has been tremendous. We're very thankful for that and very focused on that. But people love coming here, and they really enjoy the relationship and the experience. Beyond that, especially in the employer arena, where folks are focused on how much is this costing, it is a predictable expense up front. So there is a difference in terms of, hey, you are paying something up front for primary care, and generally that comes across initially as an increase in expense. But the downstream savings are proving out throughout the country when direct primary care is structured with a forward-thinking plan. Part of that is because we have total independence. So we are able to send folks to wherever is the best place for them to get the best care for them at the right price. Because we, in general, are not affiliated with a system where there's incentives for us to stay within that system. So we really can, in effect, steer, if you will, patients to higher value downstream partners when that is warranted. That being said, we generally say about 80% of somebody's needs we can handle here.
Yeah.
Because we have the luxury of time and we're not on the hamster wheel, as we discussed before. We handle, we really, and some people say, practice at the top of our license. We develop great relationships that are trusting with our patients. We're able to lean in and do things that are more specialized because we have that time, try to avoid the chronic issues, the downstream related costs. And so what you're seeing in our DPC and in various other DPCs is you're seeing decreased referrals to specialists, decreased utilization of urgent cares and emergency departments, decreased hospitalizations, and each of those buckets are extremely expensive, especially in self-funded plans. And so as a result for employers, those downstream savings, generally far outweigh any upfront, albeit predictable, cost to adding DPC into the plan.
Yeah, absolutely true. As we've seen, one trip to the ER, often more than half are unnecessary, from all the data we see. One trip to the ER, that cost would pay for 2 years of you as a all-you-can-eat kind of model doctor. I mean, it's amazing when you look at the waste in some of the ER visits. But last thought is that you hit on it. About 10% of a budget for healthcare for an employer would go to Lantern Health or to a DPC of your quality. And as you mentioned, about 80% of the care for those patients could be had within the walls and conversations that you have. So for employers out there that are thinking about this, the ROI is tremendous. The predictability is tremendous. The efficiency is tremendous to say, hey, let's take 10% of your total budget and pay it to a local, not on Wall Street, but on Main Street physician, and our people that subscribe to that model are going to get about 80% of their care delivered locally and efficiently and effectively, thereby reducing their cost to zero and the employer's cost. What's the future hold for this? I mean, what are you excited about in the future?
My bias and my hope is that this becomes the normal, the standard status quo form of primary care across the country. It's very early, but we are seeing the growth curve start to trend upward. So in essence, the number of physicians that are getting into this is growing, and that growth is accelerating. So that, I think, is really positive. Employer adoption of this is a big driver for that. Over 50% of Americans get their health benefits through their employer. And so we are grateful that employers are seeing this as a real value add and are helping us to grow the movement so that we can get more and more physicians in primary care doing direct primary care. So I think that's what I am excited about, is really trying to be a part of this becoming more of a, there are still quite a few people who have never heard of direct primary care, probably more than not. And so really just trying to grow the movement, both within our state and regionally and beyond.
Yeah. Well, and you're the best example. As you said, you had around 50 employers already, and you're opening up a new location in South Asheville soon. And that's just, and big plans for the future. So first of all, thank you for all you're doing. Thanks for sharing with us today. And we'll keep an eye on all the growth at Lantern and all the good things you're doing up there in the mountains. So thank you, Dr. Ben.
Thank you, Patrick. Really appreciate the opportunity.